pulmonary hypertension. All good. So, I would like to quickly understand if the audience I'm speaking to does really understand pulmonary arterial hypertension. So, before we begin, can somebody say what is pulmonary hypertension? Let us make it an open house because otherwise I'm the only one talking throughout the thing. Yeah. So, do
Yes, sir,
we
that's a great.
do
No, we have
we?
a lot of doctors. We have Dr.
Yeah. So,
Innocent.
let's understand what is pulmonary hypertension in today's definition, today's term. What is pulmonary hypertension?
Dr. Ivan, Dr. Innocent.
Everybody is free to participate. Trust me, I made a million mistakes before I knew these definitions by rote. I'm sure I have made a million mistakes. So please don't, you know, please don't feel challenged to not answer because if it is such, then the purpose is lost. Because then you will still send me patients with left-sided heart. Yeah. Go
Yeah,
ahead.
yeah. Abu
No
Bakr,
problem.
please go ahead.
Go ahead. Please do.
Please unmute yourself and go ahead.
All right.
Go for it.
Good afternoon, doctor.
Good afternoon. Good afternoon, sir.
Yes, pulmonary hypertension, as I knew it, happens to be when the mean pulmonary arterial pressure is 25 millimeters of mercury or more when
Yeah.
measured by um a
Okay.
catheter
Yeah.
measured from the right side of the heart. Of
Mhm.
course, with other clinical features in support, clinically, patient might come with difficulty in breathing, chest pain,
Yeah.
generalized body weakness with other cardiovascular symptoms, and then examination wise as well, patient could have features of heart sounds, the S2 splitting with prominent P2. There could even be a third heart sound.
Mhm.
And of course, even investigations could be in support. Basically, that. But you are the specialist, sir, so I would like
Phenomenal.
to learn more.
Phenomenal, doc. So you basically answered the way I was taught pulmonary hypertension when I was a postdoctoral trainee. It is there is a slight change in the definition today. That's the reason I asked that. Like, answer what is a so today any MPAP or mean pulmonary artery pressure more than 20 millimeter mercury has started to be called as pulmonary hypertension and not 25. So PH by definition today has an MPAP more than 20 millimeter mercury. Hemodynamically, the classification still remains quite similar: pre-capillary, post-capillary, combined pre and post-capillary, and exercise-induced pulmonary hypertension. This is a quick. I already know I'm sharing, mate. So yeah, so the Zoom keeps on telling that I'm sharing my screen and coming in the middle of it with a popping bar, which is quite irritating. So yeah, so this is the hemodynamics of pulmonary arterial hypertension. As we understand, as we continue to say, it has been named officially named as pulmonary hypertension or PH, and not PAH or pulmonary arterial hypertension. But for somebody that came with a pediatric cardiac surgical background to start off with, I still lovingly call it pulmonary arterial hypertension because that is the way I was taught what pulmonary hypertension is. So, looking at the fourth chamber pressures, you should have an RA pressure of somewhere around 2 to 5 millimeter mercury, and LA pressure somewhere between 5 to 8 millimeter, and RV pressure of somewhere around 25 millimeter mercury systolic, and an LV systolic of about 120 millimeter mercury. Given that definition, a mean pulmonary arterial pressure should be somewhere around 15 or ideally speaking 25 over the combined LA plus RA pressure. Today, earlier it used to be called as a mean pulmonary artery pressure more than 25 millimeter mercury as the beginning of pulmonary arterial hypertension, but today the number has come down to 20. And as you see, it is very easy to imagine the lung at the center of both the hearts, the right and the left heart, but actually they are placed in opposite way. The heart is in the center and the lungs are on either side. So this is the new hemodynamic definition for pulmonary arterial hypertension as accepted in the ESCTS, STS, ERS, and AATS meeting in 2023, which says that a pH is any MPAP more than 20 millimeter mercury, includes all clinical subgroups, precapillary being the one which is with a raised PVR, and post-capillary being one which is without a raised PVR. If we are to remember it in a very simple term rather than complicating with pulmonary capillary wedge and arterial wedge and so on and so forth, just remember that pre-capillary will have a raised PVR, post-capillary will have a low PVR. Pre-capillary is typically what is the pulmonary arterial hypertension, which is basically the lung disease or CTEPH or any vascular choking in the forward flow of the right ventricle that is causing the pulmonary hypertension. Any post-capillary pulmonary hypertension is basically whatever is regurgitating from the left side of the heart because of a valvular stenosis or huge valvular regurgitation, something that is known as the diastolic flow reversal in echocardiographic terms. The PVR won't be high because the post-capillary pulmonary veins will behave in a way that they are basically capacitance and not resistance vessels, so they can accommodate a lot of this regurgitant volume or a lot of the volume that can drain to the left heart because of mitral stenosis or things like that. Exercise pH is again a different concept. It is basically the mean pulmonary arterial pressure over the cardiac output slope. And at exercise, if this slope rests at more than 3 millimeter mercury per liter per minute, we call it exercise pulmonary hypertension, or basically exertional pulmonary hypertension. So this is the classic pressure trace for an aortic pressure curve, followed by you can see there is this RV pressure trace without any diastolic pressure. Is the is the pointer visible on the screen? Yes. Is the pointer visible on the screen? I'm trying to. Oh, yes. What is? Okay, yeah. It should now be visible. So you can see this is a typical LV pressure trace, and this is the RV pressure trace. There is no diastolic lift in the RV pressure trace. The moment your swan passes into the pulmonary artery, this is what is known as the diastolic lift, which indicates that now we are basically into a structure that also has a diastolic pressure or a back pressure. So ideally, the mean pulmonary artery pressure was assumed to be somewhere around 15 millimeter mercury. And the mean pulmonary artery pressure more than 25 millimeter was taken as pulmonary arterial hypertension. Today, the number is 20. Coming to the classification of the WHO classification, just remember very easily. Group 1 is basically isolated, Group 2 is left heart, Group 3 is lung disease, Group 4 is vascular or what was earlier called as CTEPH, and Group 5 is mixed. The most common ones that we see are basically Group 2 and Group 3, which is basically due to left heart disease, due to unmanaged mitral stenosis or severe mitral regurgitation, due to the rheumatic valvular heart disease that we see in the developing world. A lot of them can also be due to idiopathic pulmonary fibrosis, interstitial lung disease, diseases that cause the destroyed lung, obstructive sleep apnea. All these can give rise to a stiffened lung, which can give rise to a lung disease and hypoxia, which causes a pulmonary. Coming to Group 4 was traditionally called as CTEPH, or the chronic thromboembolic pulmonary arterial hypertension. Now it's called CTEPH, or chronic thromboembolic pulmonary hypertension. It also includes any other vascular anomaly, which can be an acute pulmonary emboli, anything that is causing obstruction to the forward flow of the RV forward flow, which is causing a pulmonary arterial hypertension. Pulmonary hypertension is called as a Group 4. Group 1 remains the rarest of the rare, which is idiopathic, hereditary, at times connective tissue disorders, congenital heart diseases that can, where there is persistent pulmonary hypertension. So this was the most tough group to be treated. And somebody with an idiopathic or a hereditary or a congenital persistent pulmonary hypertension was nearly destined to die. Today we will talk how multidisciplinary care has completely changed that gamut of patients. Yeah. So this is again a picture from I think it's from Circulation, which says that pulmonary arterial hypertension or the idiopathic pulmonary arterial hypertension still remains the rarest of the rare presentation. There's plenty of left heart disease, plenty associated with lung disease. It can be severe, non-severe. It can be isolated precapillary or combined pre and postcapillary hypertension if it's a left heart disease. But remember, in these diseases, traditionally the PVR is not raised. Traditionally, in a precapillary hypertension, the PVR is raised, or mixed hypertension, the PVR is raised. PH associated with lung disease, PH associated with pulmonary arterial obstruction, which is basically any vascular anomaly to it. And then there are multifactorial PH, which is basically in hematological, systemic, and another disorder. All of these mixed disorders, more or less, will resolve with resolution or resolving root cause. But if it's a pulmonary arterial hypertension, which is idiopathic or hereditary or a persistent pulmonary arterial hypertension, which has been proven by right heart cath, the answer was prior to the Sotatercept magic drug, the answer was more or less death, an untimely death, young age death. Same thing. So it was very nicely summarized by, I think, Dr. Abu Bakr, who said, about the clinical suspicions, pre-testing probabilities, and how do we confirm the diagnosis. So dyspnea, chest pain, edema, the typical right heart failure findings, abdominal swelling, palpitation, orthopnea, pedal edema, presyncopal status. So these are all the presenting symptoms. Um, heart disease, COPD, connective tissue disorder, interstitial lung disease, um, chronic hypoxemia due to things like uh, sleep apnea, high risk medications, venous thromboembolism, hemoglobinopathies, sarcoidosis, uh, immunosuppressive disorders like HIV, schistosomiasis. These are all basically the causes or comorbidities that which add on to people that are having pulmonary hypertension of some or the other sort. Heart disease will classically have type 2, COPDs, ILDs, chronic hypoxemia will classically have class 3. Drug-induced and connective tissue disorders can have mixed, even drug-induced can be isolated pulmonary hypertension. End-stage kidney disease, hemoglobinopathies, these will all be mixed pulmonary arterial hypertension. So whenever you are evaluating a pulmonary hypertension, it is very important to know the comorbidities, take a very detailed family history, look for any history of sudden cardiac death in the family, look at the echocardiogram findings, try to remember two very classic values, that a TRZ less than 2.8 and a TAPC more than 1.8 is generally indicative of a favorable outcome in pulmonary hypertension. Just remember the numbers. TAPC more than 1.8 and TRZ less than 2.8. If that is the case, the pulmonary hypertension is almost always mild, easily treatable with a better outcome. Yeah. Laboratory testings like pro-BNP, although I am not a huge fan of pro-BNP because pro-BNP is elevated in a lot of other acute illnesses. The perfusion scan with a VQ mismatch, though not used much today, but still remains a very cornerstone investigation in identifying pulmonary hypertension and pulmonary function testing, obviously. Pulmonary function testing per se in pulmonary hypertension will not give a huge, giveaway because it can basically differentiate between basically the airway obstruction, whether it is an extrathoracic, intrathoracic, whether it is a restrictive or obstructive physiology. So its role in pulmonary hypertension is not much, but yes, it can indicate a mild obstructive restrictive mixed pattern of obstruction. The diagnosis in a pulmonary arterial hypertension is not an echo finding of a TRZ more than 2.8, is not an echo finding of, pulmonary regurgitation, is not an echo finding of a TEPC less than 1.7. The one and only finding that is important and that is necessary to confirm pulmonary arterial hypertension is to have a right heart cath. Many a times we would see that. Hello.
Okay.
All good?
Yes, sir, all good. I think somebody joined.
Okay.
Just
So many a times we see that pulmonary artery hypertension diagnosis has been made based on an echo, which is so wrong. It could be an isolated RV failure giving rise to severe tricuspid regurgitation. It can be a tricuspid valve organic disease giving rise to tricuspid regurgitation. So every tricuspid regurgitation is not associated with pulmonary hypertension. Yes, every pulmonary hypertension will give rise to tricuspid regurgitation, but measuring tricuspid regurgitation and using that 4V square plus a RAP or right atrial pressure, the formula for calculating the pulmonary arterial systolic pressure, is potentially and probably the wrongest possible thing to do under the sun. You always need a right heart cath mandatory for diagnosing anybody with pulmonary arterial hypertension. Pulmonary hypertension. So coming to the low risk status in PH, no syncope, no progression of clinical manifestations, absent symptoms for heart failure, 6 minute walk distance of more than 440 meter, R area less than 80 centimeter square, TEPC by SP more than 0.230, an anti-pro-BNP less than 300 nanogram, an RV ejection fraction more than 50% or 54%, the stroke volume index of 740 ml per meter square BSA, and a right atrial pressure less than 8 millimeter mercury with a cardiac index more than 2.5 liter will ideally tell you that this pulmonary hypertension is neither severe nor life threatening and is basically a low risk status patient. Now that we know how do they present and how do they progress and what are the low risk subsets and what are the high risk subset, now we should know what are the things in our armamentarium or in our arsenal that we have to treat them. So ibuprostanol, which is an intravenous prostacyclin derivative, it increases the exercise capacity, drastically improves. Then we have iloprost, which is again a multiple repeated dose inhalational prostacyclin derivative. The only contraindication to the use of it potentially being that patient can very often have an extreme dry mouth and an allergic reaction to the inhaled iloprost. We would frequently tell people that you can have severe pruritus and itching when you are put on iloprost inhaled, but if you want relief of your breathing symptoms, you might have to constantly give us feedback, and we might have to alter the dosage of the medication. It is multiple times a day, inhalational dose. It needs to be adjusted for patient to patient, not that no two patients the same weight can have the same amount of iloprost just be fine. Other prostacyclin derivatives include treprostinil, selexipag, and then there are the endothelin receptor antagonists like bosentan, emrisentan, mesentan, and then the traditional phosphodiesterase 5 inhibitors, the sildenafil, sildenafil, and the newer soluble guanylyl cyclase inhibitor, which is basic simulator, which is basically your ESC-GUAT, Verisi-GUAT, all those GUATs. So how do we prescribe? Now that we know all the medications, how do we prescribe somebody with diagnosed pulmonary artery hypertension their medication? I would like someone to just respond from the group. I'll be really happy. So how if somebody comes to you, you find with an echo that he's got a huge TRZ of 5 centimeter per second, his calculated PSP somewhere 110. You are the treating physician. What would you do? You would give him some medications, right?
Hello. Anybody? Let's make it interactive.
Yeah. Anyone? I mean,
Dr. Abu Bakr,
it's absolutely fine to have to kind of make mistakes and say things that are not very probably not the most um,
Dr.
technical.
Bills, Dr. Paul. I think we have Dr. Kwete also here. Anybody, please? Dr. Miriam, we have
It's
two
okay.
doctors here today. We have two Dr.
So
Miriam today.
we traditionally today potentially start with um, the lowest possible dose of phosphodiesterase 5 millimeter. So my favorite drug today probably will be tadalafil, to start with a 5 milligram of tadalafil about once a day if it is a 60 kg or above patient, or 2.5 milligram of tadalafil once a day if it is a less than 60 kg patient. Gradually build it up over a week and add a santan to it, which can either be bosentan, emrisentan, preferably mesitantan, because mesitantan improves two things. In all studies, it has been seen that mesitantan will not only improve the composite end result, but it will also reduce the number of MSCC events or any clinical worsening events that we face in 1, 3, and 5 years. So mesitantan tadalafil combination therapy might be the choice from the second week onward. For an adult who is 60 kg and more, I would probably give them 10 milligram of macitentan with 5 milligrams of tadalafil once a day early in the morning while he's in the active hours to prevent any drug-related hypotension, right? The second drug of choice, though people are very, very uh, reluctant to take it because of multiple reasons. One, they might have swollen tongue, they might develop severe pruritus, they might develop severe itching in the body, and they might present to this kind of red swollen tongue is selexipag, which is a selective prostacyclin receptor agonist available orally and given in a 200 microgram once a day dose, twice a day dose for most adult patients. For anybody below the weight of 50 kg, we are probably still preferring 100 microgram twice a day dose. So one of the sentans or an endothelin receptor antagonist along with the phosphodiesterase is 5 inhibitor along with the prostacyclin derivative oral or inhalational is the first triple therapy that should be tried out in every patient before you have given up, before you have said that, oh, your pulmonary arterial hypertension is just not reacting, it's just not going to improve. You cannot do that. Also, right heart catheterization is important because it is during the right heart catheterization they will be able to comment whether this pulmonary vascular resistance is vasoreactive or it is not. If there is a vasoreactivity, there are plenty of drugs that can kind of come to your rescue. Drugs like riociguat, vericiguat, the newer magic drug on the block, which is Sotatercept or sold as Winrevair in many countries, right? Okay. So now this is the magic drug which has kind of completely changed the face of idiopathic or hereditary or persistent pulmonary hypertension of the newborn. So people were placed on a double-blind randomized control trial for people that are proceeding to a death, lung transplantation, or hospitalization for more than 24 hours, who have been either put on a placebo therapy or on a sotatercept therapy. In a sotatercept therapy, it was seen that there is about a 38% improvement in symptoms, or more than 40% of the patients who were put on Sotatercept did not have a disease progression, did not require a lung transplantation, did not require a prolonged hospitalization. So that was one of the major points that came from Sotatercept studies midterm, so much so that the approval process was fastened up by FDA, and Sotatercept was granted a full FDA approval last year for treatment of persistent pulmonary arterial or primary pulmonary arterial or first degree pulmonary arterial or group 1 pulmonary arterial hypertension. The next treatment that is available and is very complex is basically this pulmonary endarterectomy. It is an absolute surgeon's joy to go and do the surgery, but it will nearly break your back. You'll have to circularize the patient, go on bypass, and cool down the patient to 16 degrees for close to 8 to 10 hours when you would have emptied both the lungs of all the blood clots. So CTEPH or CTEPH surgery is another important aspect of pulmonary hypertension care. So this is basically a sum and substance of what was said earlier. Thank you. So I would appreciate some questions on pulmonary arterial hypertension more than me. See, I can go on telling about a lot of these things for another. So I really want the house to interact because otherwise there is no knowledge building. And this is the pulmonary hypertension clinic team at Artemis Hospitals in Gurgaon. Thank you.
We request the audience to please ask your questions or discuss any patient case notes with Dr. Biswarup. Biswarup, in the beginning of your talk, you mentioned, that the first category, which you
Yeah.
said often, but now with multidisciplinary approach.
Yeah, so group
Can you
one,
tell a little bit more
group
about
one,
that?
group one nearly met to death in a few years, even when I was training. So group one pulmonary hypertension is like tender love and care, leave him alone, let him die in peace with friends and family. Today, people that are put on this combination sotatercept therapy, which is somewhere around $10,000 US a vial. So, it is a very expensive therapy. It is once every third week. It, raises the risk of having stroke and other things. So yeah, all of that can today be mitigated. People on sotatercept are going on to live upward of 70 to 80 months now that the trial has been on for 7 years. ever since it started. And it is the only trial for a major pulmonary hypertension drug that was stopped midway and granted an FDA approval. So you can understand that 17% death or adverse outcome in the Sotatercept group vis-a-vis almost a 55%. And this cannot be a um, statistical error where you can kind of put in five central tendencies and say that, oh, it is marginally better than this and this p-value is more. So it is a clear-cut indication that this therapy is a game changer in terms of pulmonary arterial hypertension or group 1 pulmonary hypertension. So I would like to know from the house, how much importance do you guys pay to the Woods unit in terms of pulmonary vascular resistance, or what is the threshold limit till which you would like to try medical therapy in somebody with pulmonary hypertension vis-a-vis how would you want him managed if his PVR is high? So what is your break of PVR? Anyone?
Dr. Bales,
Hey.
would you like to contribute? I think we have Dr. Kwete from Device Samsung. Dr. Kwete, would you like to contribute?
You're free to give your answer. I mean, that's okay.
Dr. Abubakar has, I think, written in the chat, sir.
Okay. I will
His question
follow.
is regards the treatment, sir. So you suggested use of low dose phosphodiesterase.
Okay, my question is with regard to the treatment, is the use of low-dose phosphodiesterase 5 for status. What is strategy does one employ to counteract the effect of they're also used in erectile dysfunction. So yeah, I mean, once you start anybody on a phosphodiesterase inhibitor, you have to inform them of two different things. One that they are going to have or they might suffer syncopal episodes because of hypertension, and they will have kind of a prolonged erection. More or less, if it is a younger male, it is, they will most definitely need a counseling with one of the grief counselors or one of the clinical psychologists who will have to sit him down and tell him, there's nothing wrong about you being or you feeling longer erections, and you will have to counsel them. This is basically a part of your treatment. As you build up the dose, there is also kind of a tolerance to the phosphodiesterase 5 inhibitor, and the kind of the length or the duration of erections will gradually come down, or they will start feeling less bothered by it. They will learn some defense mechanism to circumvent it, either wear a loose pair of clothes or kind of stand cross-legged or do something which does not make it socially a very awkward thing for you. But they will definitely have a kind of a reaction mechanism developed to it. We in our practice generally counsel them and tell them, oh, look, you're just gonna be fine. It's just good to be horny for a while. I mean, I would just say it that way, without being sounding too technical. But my starting dose is always 2.5 milligram for anybody less than 60 kg and 5 milligram for anybody more than 60 kg.
Thanks, Dr. Abubakar, for your question. Would you like to contribute more or ask more questions? Dr. Gadaga, would you like to contribute?
No, no, not at the moment.
Okay. Dr. Miriam Chipimo, ma'am, would you like to contribute?
Questions?
No, Varun, this is way beyond my clinical expertise right now.
But ma'am,
I really appreciate the lecture. Yeah.
That's okay.
Uh,
But
Dr.
remember, anybody that presents with a fatigability, with prominent right heart failure symptoms, pedal edema, raised jugular venous
Mm,
pressure,
yeah.
panting, difficulty in breathing, a little
Yeah.
bit very mildly cyanosed because of the low QP. So the
Mhm.
easiest thing out there in the periphery is an echo, which is not the answer, but then the answer, because not many people can do a right heart cath very nicely. So an echo
Yeah.
that shows that there is no gross RV dilatation, there is no gross tricuspid valvular anatomic pathology, but there is a huge amount of tricuspid regurgitation, anything more than a 3 meter per second. Just try to pick them up and kind of send them to a targeted PH clinic or a PH clinic. The three major, okay, somebody wrote to me. Hi. So, what are the three major pharmacological pathways targeted in PH? So, the three things that you want to do is you want to inhibit the phosphodiesterase 5 so that there is a vascular relaxation. You want to stimulate the guanylyl cyclase so that at the arterial level, or if there is a kind of pulmonary hypertension which is causing an RV back pressure dysfunction, that to go away. And what sotatercept does is sotatercept prevents the formation of smooth muscle cells or hypertrophy of smooth muscle cells at the vascular level, and preventing them does two things. A, it causes a dip in the pulmonary arterial pressure very quickly. B, it decreases the pulmonary vascular resistance first and then the pulmonary arterial wedge pressure. So the philosophy of sotatercept, the philosophy so far was to stimulate one or the other receptor or one or the other enzyme to kind of cause a vasodilatation. It was never kind of, I would say, sotatercept acts almost like or somewhat like a chemotherapeutic drug, as in it prevents the smooth muscle proliferation at the pulmonary vasculature level to decrease the pulmonary arterial pressure. So that is the game changer. So far we are what stimulating inhibiting phosphodiesterase 5 and stimulating signal, you know, cyclic guanylyl cyclase CGMP, but we were not doing anything to the arterial or the vascular pathway per se.
Dr. Biswarup,
Uh,
comment from Dr. Innocent, because you
I
had once
MPAP
asked
is a generally
PVR
reserved
and
for
good
with
units.
an MPAP over 25 in PVR of 3 Woods unit or higher. No, today anybody with an MPAP over 20 and PVR more than 2 Woods unit should be initiated on a therapy. Should be initiated at least on a phosphodiesterase 5 inhibitor along with a endothelin receptor antagonist like macitentan or emrisentan or bosentan. You may not go on to use a selexipag or an oral prostacyclin analog, but you definitely have to put them on double therapy. And if there is any increase in their MPAP, you have to introduce the third component, which is a triple therapy, and see if he or she shows any signs of improvement. If there is early vasoreactivity, if there is a decrease in the pulmonary artery pressure with starting drugs like macitentan or tadalafil, then these patients normally tend to have a better course or better outcome. 32-year-old woman with sildenafil remains symptomatic. What is the next option? So next option would be to add endothelin receptor antagonist like bosentan or macitentan. Still symptomatic, start her on oral selexipag. Not possible while she is 32. She might give Winrevair or Sotatercept a definite shot. So we currently have a patient who's coming from the French Guyana, came in with an RV systolic pressure of 138 millimeter mercury as measured in the right heart cath. He's taken a single shot of sotatercept almost 2 weeks down the line. His pulmonary arterial systolic pressures this summer hovering around 105, 110, down from 138. So yes, sotatercept may be an answer, but that is once the triple therapy has not been able to respond for at least 6 months to a year. Thank you so much, Chris.
Thanks, sir. If there are no more questions, we can conclude the session with
It's
your
a
comment.
reasonable interaction today. Thank you, Varun. Thank you so much.
But just 1 minute, sir, before I would like to thank you and everybody present here for joining us on a Sunday. And also, yesterday in India, we celebrated our Independence Day. And we have one more question, sir. Uh,
Mhm.
Why does PH cause RV failure rather than LV failure initially?
Okay. So what is pH? pH by definition is a pressure overload. And your RV is basically your volume handling ventricle. It is not your pressure handling ventricle. So if there is pH, then remember the RV afterload has severely increased. The RV is something that is used to a lot of preload. You can put a lot of volume and the RV will not fail because it is a volume handling ventricle. It is the kidney bean shape, or which is the convexo-concave shape, which is the most efficient design in the entire world to accumulate volume. From a convexo-concave, it can go to a biconvex shape. It can have huge amount of volume load and still not fail. But the LV, on the other hand, is the pressure handling ventricle. So a lot of pressure is not going to kill the LV because it's a thick thing. It might hypertrophy. But the RV will initially hypertrophy to a point, and beyond that point, it will just fail. So RV hypertrophy, secondary to pulmonary arterial hypertension, is going to fail the RV earlier than the LV because the RV by definition is the volume handling ventricle, the LV by definition is the pressure handling ventricle. What are the antihypertensives safe in pregnancy? Okay. Is amlodipine safe in pregnancy? Probably yes and no. After the first trimester, amlodipine or any calcium channel blocker for that matter is reasonably safe. If he or she is diagnosed with an eclampsia or a hypertension during pregnancy, probably the safest agent will be a direct alpha agonist, which should be like something like a prazosin. What causes a loud P2 in PH that you got to reduce friend? Why would a P2 be loud? If you have to squeeze a fluid through a high pressure channel, then your pulmonary artery is basically opening to a high pressure circuit. So when that pulmonary artery closes, it will not close like this, it will close like this. That tap is the loud P2.
So we missed one question from Dr. Innocent about viral proteins.
How does viral protein lead to pulmonary
Lead to pulmonary hypertension?
hypertension? That doctor. See, viral proteins would basically cause deposition in the lung interstitium. The interstitium would start getting stiffer. So you're basically trying to ask me how does a viral pneumonia or how does a viral influenza cause ARDS and PH? Is if I'm getting it right, Dr. Innocent?
Well, thank you so much, Dr. Biswarup.
Yeah.
I'm asking regarding to patients with HIV case.
Okay. So for HIV, you need to understand that viral proteins, you know, will basically go on to cause an interstitial stiffness in the lung. That stiffness is going to squash your blood vessels in the lung. The other thing that will happen along with any immunodeficiency or any immunocompromised state is that in an immunocompromised state, because there is a lot of immunocompromised state, there is going to be a smooth muscle hyperplasia. The smooth muscle hyperplasia, along with the stiffening of the interstitium, is A, going to make the vasculature narrow, B, going to crush on top of it. So that is the mechanism of pulmonary hypertension in the patient of HIV.
And from Dr. Gauthier. So great presentation, Doctor. A very relevant topic.
But Dr. Ivan, always remember the pulmonary valve opening, the pulmonary valve closing, the pulmonary valve opening, closing, loud P2. Never forget that. Can you think of a loud, since you've asked me about a loud P2, so do you found the loud P2 in a tetralogy of fellow? Dr. Ivan, are you a cardiothoracic or cardiology trainee by any means?
Dr. Ivan? I think so. Dr. Ivan is doing his residency right now. So,
Okay.
but
Is,
I'm not
is,
sure about the specialty.
is,
Dr.
is
Ivan,
he,
can you come? Can you
Dr.
respond?
Ivan, you might give it a shot. You are a cardiothoracic resident, so does the tetralogy always have a soft P2 or it can also have a loud P2? It's a trouble territory. I had in my days, in my board finals, I had a adult tetralogy with a loud P2. I said loud P2. read up. There's a physiology called the PSPH physiology. It's a very, very rare physiology, but it does exist. PS not necessarily means a low pulmonary flow. It can also mean a high pulmonary flow because of collaterals causing a raise in the pulmonary arterial pressure and pulmonary arterial hypertension. And in that case, despite the tetralogy, despite an RVOT stenosis, you will still have a loud P2. Because in an RVOT stenosis, the pulmonary valve is supposed to open like this and close. Soft P2. But if it opens like this and it again slaps, no matter how small it is, the P2 will still be loud. Thank you so much, guys. No more questions, I guess. Thanks a lot.
We have. Okay, Dr. Innocent is clear. High pressure in the pulmonary artery that slams the pulmonic valve shut forcefully. I think he is responding to what you were
That
asking.
is more or less, yeah.
Yeah, and thank you everybody. And I would want to share our joy of our Independence Day. Like in 1947, our ancient civilization, it was born as a modern nation. And interestingly, while we are building this Africa to India axis, one of our founding fathers, Mahatma Gandhi, he practiced and perfected his civil disobedience and non-violent non-cooperation movements in South Africa. So Indian independence has a strong connection with Africa. And thank you all for joining us, sharing this joy and wishing for when we talk of freedom, the freedom to access good healthcare, what is available is also a right of humanity. And thank you all for contributing it and taking taking this further. Thanks all. Thank, thank you everybody.
I'll be away for next couple of months. Keep me free because I'll be traveling a lot in September and October. I should settle down back by November and happy to do any classes from then onwards.
So like Artemis cornered me into giving them the whole quarter this time. Now the next quarter BLK has cornered me.
Okay.
Okay, why are being partial to Artemis? So, but after
I'll
that, sir, we will.
Well, I'll be traveling in between. So I'm traveling
Yeah.
2 weeks in September. I'm traveling 2 weekends in October. I'm traveling the next weekend to Hyderabad. So I'll be constantly traveling now.
Mhm.
Been almost run out. I was an entire day working today. I'm almost unslept the whole night. When you called me in the afternoon, I was still working in the hospital. I still have to go back to the hospital again to see patients. So it has been a run over weekend, but that's okay. Happy to interact with people. We'll definitely come back and do some more classes whenever you find
No,
time.
no,
Done.
I'll coordinate with you, sir, based on your availability,
That's
and
fine.
we'll
Thank you so
work
much.
out the schedules. Thank you, sir.
You guys have a good time. Bye bye.